Dr. Namson Lau, welcome to Project 100. How are you going?
Thank you for inviting me. Great, thank you.
So you're a consultant physician and endocrinologist. Maybe you could quickly, and you're at Liverpool and RPA, Royal Prince Alfred.
Yep.
You're a conjoint senior lecturer at UNSW and the University of Sydney.
Yep.
But what is an endocrinologist? Could you just explain what that is first? And then maybe give me a bit more background about how you've studied and what you've achieved.
Yep. So endocrinologist is a medical specialist in hormones. And a lot of what we do now is in the diabetes space. So I guess we'll talk about that.
That's your area of specialty, diabetes.
Yeah. So I actually am a subspecialist in diabetes and cardiometabolic health. That is overweight, obesity, and type 2 diabetes as well. Yeah.
And maybe you could just give a little bit of background in terms of your research areas, your current roles.
Yep. So as you said, Mark, I'm affiliated across a range of public institutions, predominantly at Liverpool Hospital and Royal Prince Alfred, where I trained. In my training, I completed a PhD in actually some of the things we're about to talk about, the neuroendocrine adaptation of appetite and weight. That is to say, how hormones impact appetite and weight regulation. So that's some of my research, and that's how I sort of got into the space of these injectables and these medications, these incretins. I still do a lot of clinical research. I'm a probably mid-aged, mid-career clinician researcher. And my clinical research is in diabetes in the hospital, diabetes, foot disease at Liverpool, and at the University of Sydney and Prince Alfred. It's in overweight, obesity as well.
Right. So, and one of the topics, you and I are going to talk about today, and I'm hoping you're happy to do this, is I do want to talk about semaglutides, GLP-1s, or Ozempic, which is all the same thing. It's a big topic. It's a huge topic. It's a global topic. So maybe you could just tell me exactly what is Ozempic. Like, we keep hearing about it. What does it do to the body?
Sure. So it's the trade name of semaglutide. Semaglutide is the medication. Semaglutide is part of a group of medications that are known as GLP-1 RAs, or now we increasingly know them as incretins as well. So that's those are medications that are predominantly taken by injection, and they have very powerful effects on. I can go through the history, but in terms of what they do, they have very powerful effects on appetite in terms of regulation of appetite. They suppress gut and brain hunger. I guess that's a very simple way of understanding them. They also improve the effectiveness of how you metabolize and process food. So they slow down gut transit time, as to say that food takes a little bit longer to go through the gut. It increases the absorption. It actually works with the body's own insulin production to make it more effective. So you spend less time with the glucose levels into the bloodstream and more into the cells. And it also has really interesting effects, increasingly being researched. This is the brain chemistry stuff. It actually might work on reward centers as well, which is part of how it actually suppresses appetite. And it also actually there's been some evidence showing that it actually changes the metabolic rate, perhaps by working on brown fat. That's a metabolically beneficial fat. So it's really like the medications that have a very powerful range of effects that go beyond what they're originally designed for, which is actually for diabetes. They were originally diabetes medications.
And is that because diabetics traditionally, therefore, were perhaps overweight, and somehow whoever the pharmaceutical company was that designed it decided that we've got to do something to suppress their appetite?
Yeah. So people with type 2 diabetes, which is what we're talking about, the people who develop diabetes due to predominantly overweight, obesity causing insulin resistance, and that's the one that develops later in life predominantly. So that's the one which also is the really, really big numbers of people with type 2 diabetes. And that's how I got into the space, because that's really quite linked to weight. So, if you can address the weight, as you were saying, Mark, you actually might be able to improve the glucose levels. So you're right. There was medications before the incretins helped treat the sugars, but didn't actually make people address their weight. And also, they actually didn't seem to make a big difference on people's, outcomes, their cardiac risk or their risk of developing complications. And so obviously people keep on trying to look for new ways of treating diabetes, type 2 diabetes, and these molecules were actually known about for quite a long time. So people went back to them to have a look at them to see whether they might have an effect for type 2 diabetes. And once they've discovered that it not only improves blood sugar levels, but actually addresses weight, that's when people started to think about whether it actually could address, overweight, obesity without diabetes.
So when, and I don't want to sort of hang on this too much, but when somebody through their lifestyle perhaps, is become obese. And what obese is, I don't know, because everyone's different, I guess. But when there's someone who's way overweight in itself is not something that can create type 2 diabetes, but it's more. That's sort of more about causing you metabolic problems.
That's right. Yep.
But in terms of the amount of sugar in your system and the relative to the amount of insulin that your body's got to produce, that's more about what you eat every day, like or every moment or every occasion. And there probably is a correlation between eating too many sugary things, for example, and being overweight. That's more a correlation thing. Overweight is not causative of type 2 diabetes, but it's the sort of what goes with it. Am I correct on that? Is that right?
Yeah, you're right. So we know that people naturally as they age do put on a bit of weight. There's changes that, are age-related metabolic changes. But we also know that there's been a big tick-up of overweight obesity globally, firstly starting in high-income countries, but now you can see it globally. And when it sort of goes to the root causes of that problem, there are individual factors, but I believe that strongly, and so is the evidence would support this, there's sort of global factors as well. The way that food is made, our changes in our lifestyle, changes in our work habits that, we are no longer quite as active as we need to for work. Many of us are information workers or work in the knowledge space. And so those are sort of the factors you were sort of discussing that contribute to someone developing overweight obesity. So there's things that you may be able to influence yourself, but this is wider structural societal factors that are hard for us as individuals to change.
How does Ozempic actually work? So, or any of the other versions of Ozempic. I mean, Ozempic's just a brand name. But how do the semaglutides work? So, or what they call the GLP-1s. What do they actually do?
Yeah. So the GLP-1s or the incretins, how they work is that they work on gut hormones. So they were actually originally discovered as part of, looking at the pancreas's own gut hormones. And really clever people actually have known about this for a very long time, going back to the beginning of endocrinology. Like they've looked at the pancreas and insulin, and they've known that it's not just insulin.
Insulin is produced in the pancreas.
That's right, yeah. And so they've just also known about other hormones there. They didn't know much about them, but they knew they existed right in the beginning of my specialty. My specialty is actually quite young, Endocrinologists have only existed in the modern form for, barely 100 years. And the science of it. And
insulin, just to be clear, insulin's a hormone.
Insulin's a hormone.
One of the many, many hormones.
Yep. One of the main ones we deal with, but yes. And so people have gone back to the other pancreatic hormones and started to look at whether they have these effects, as we were discussing earlier. And then they created these medications based on seeing that these things helped insulin. That's how they originally sort of understood them. But then they discovered that they have these really powerful effects on other things than just insulin. So when you're asking to me how they work, I sort of explained it in this sort of complicated way. But I guess when you do the injection, these things work slowly. That's why the most common two now are weekly injections. They work on the gut hormones, as I said.
So you inject it into the fat in your tummy or on the side of your body, whatever
it is. That's right. Yep.
So it gets absorbed into the fat, and there's obviously capillaries in those areas, and they somehow grab a hold of this.
Yeah, that's right. Yes, there's small amounts there. It's absorbed slowly, in the microcirculation through the stomach fat, as you were saying. It's absorbed slowly over time. Levels do build up. That's why, they often don't work that quickly. They do take a few weeks to have effects in the way that they're used clinically. And then how they work in terms of the gut effects is that they actually quite powerfully target these receptors, GLP-1RA receptors.
So GLP-1 is a receptor in your tummy?
Yep. And they essentially, GLP-1RA receptor agonists, right? They actually turn them on. So and turning them on does something? Yeah. So it actually really reduces, in the stomach. It makes you feel fuller when you start eating, and it slows down the gut transit time. So food takes longer in the gut and is absorbed more efficiently.
So before I get through the transit time, could just go back to the GLP-1 turning on the GLP-1 chemical
receptors. That's right. Yeah.
Turning on the receptors, I should say, and they're called GLP-1 receptors, are they?
Yep.
So turning those. So in all our body, we've got these receptors looking for some sort of molecules which make them do something. Yep. But in this case, it's in the gut, and we've probably got lots of receptors in the gut, lots of different types.
That's right.
But this particular one, does it sort of make that receptor feel like it's full?
Yeah, it turns that receptor on, right? And then that receptor stays on because that's how they actually have a long duration of action. And there's also I was talking about brain hunger too, wasn't I? So they've discovered that there's these GLP-1 receptors everywhere. So there's actually ones in the head as well. And that's the stuff which is really interesting because it not only makes you feel fuller when you start eating, but you actually don't feel hungry when in between meals as much too. So you actually, the technical term is satiety, fullness. So you actually have within meal fullness. When you actually start eating, you don't feel like you're always hungry. You don't want to eat as much. And then between meals, you don't feel the hunger as much too. So that's the hunger effects we're talking about.
So you're feeling satiated all the time.
Yes. Yeah.
But both in two ways. One, when the GLP-1 receptors in your tummy are receiving the food, they're going, okay, we've got enough.
Yep.
And also between meals, your brain GLP-1 receptors are saying, I don't really want anything because I'm actually still full.
That's right. Yeah.
I mean, in a very basic way, I'm saying it's
crude. That's a really good way of understanding it.
Yeah.
The hunger part of your brain has GLP-1 receptors, and they get turned on, and they get we're actually not as hungry now.
So just for a type 2 diabetic, I guess it's more about, because if that type 2 diabetic was just eating steak, never ate fruits or desserts or sweet drinks or anything like that, there's no net benefit of this, is there, for a type 2 diabetes, that type person? Because really what it's trying to do to someone is saying, when you stop at the BP service station, because you've got the GLP-1 receptors turned on in both your brain and your tummy, you're not going to buy the Kit Kat. Which is the Kit Kat's, I mean, I'm not having a crack at Kit Kat, by the way, but the Kit Kat, which has got a lot of sugar in it, is I don't feel like that anymore, and therefore I'm not going to have it. Therefore, as a type 2 diabetic, I'm sort of helping my the insulin issue that I currently have coming from my pancreas. Am I sort of right now?
Yeah. So yes.
Sort of right.
Sort of. Yeah. So you're right. You obviously don't feel as hungry. You don't want to eat as much. And when you do sit down and eat food, you want to eat less. People with type 2 diabetes generally have had overweight, obesity, as we were discussing before, and was talking about how there's a range of dietary things that contribute to it. It's often only small parts of overeating, isn't it? Like, so we know that ourselves. We can only eat a little bit more. For example, I said I was mid-age, mid-career. I've also got mid-children. And as a result, I've learned that if you sort of eat your kids' food to clean the plate off, you actually are eating more food, aren't you? Right? Yeah. And you may not think it's very much. It's only a small amount. But if you do it repeatedly, and my kids are not very good eaters at times of life, including now when they're teens.
Especially if you've been taught not to be wasteful.
Correct. And that's my cultural background, as we're just alluding to previously. Yes, not taught to be wasteful, right? And so that's something you have to cognitively shift and change that behavior. That's the first thing for me as a person. But in terms of developing overweight, obesity, small amounts of that over time lead to this weight gain. And so this person now may be trying to really change their diet, as you're sort of alluding to, by upping their protein content and cutting back carbs, and it may actually work for them. I've seen people that I treat with type 2 diabetes do big dietary changes.
But that's more cognitive. We're talking about the people here who probably cognitively can't adjust.
Well, I was about to say, it's really hard to maintain those things long-term, isn't it?
Yeah.
Right? We know that on balance, it's very hard to maintain any dietary intervention long-term, especially a more radical one. And so therefore, these medications, have this role in treating, the people with type 2 diabetes in a way that both makes their bodies more efficient in terms of processing food, and makes and uses their own insulin better. But I think really powerfully, by doing these brain and gut hunger signals and changes to them, it actually facilitates weight loss, and that actually is a really big treatment for type 2 diabetes.
And is it a permanent thing? In other words, do you have to keep taking it? Because do the receptors turn off if for some reason, and do they turn off for a longer period of time as a result of no longer turning them on? In other words, because they're getting stimulated to be turned on.
Yep.
If all of a sudden you withdraw from this, do you go back to normal or do you go back subnormal?
Yep.
What are you finding?
That's a really, really good question, actually. So there was both the clinical data that says, yes, you do have to take these medications long-term.
Long-term means what, though?
We recommend, I would say to my patients, if I'm starting them on the medications now, look, we're talking about using this medication for years.
Oh, really?
Yeah. Especially if they meet the clinical criteria and have, high ranges of obesity. In terms of the data and how they've looked at the medications, the companies have done trials and they've been published. What happens if we gave this medication for 12, 18, 24 months, and then half the group went back onto a placebo injection and half went on to the active treatment.
Wow, what happened?
There are people who, all groups lost weight up until the point and improved, outcomes. But once you switch over to placebo, the ones that went on to placebo regained a lot of that lost weight. Now, it wasn't back to where they were, but that study ended at a certain time point, and the trajectory was still upwards at that point. And the other example I can give is from my real-world experience. You're probably going to ask about the supply shortage, or most of your listeners would know about that. And obviously, patients of mine who've done really well on these medications, especially the ones who'd been started on them before they became well-known publicly, and were really mostly being used for people with type 2 diabetes. Some of them did really well in terms of weight and diabetes control. And we had this sort of unfortunate, sad real-world example of what happens when you stop this medication. Almost everyone put weight back on. The trajectory was different, though. I saw some people put less weight on and some people put more weight on. And some people were slower in their weight gain and some people were faster in their weight gain as well. But in the end, take them off for long enough, everyone relapsed to some extent with their weight and diabetes control.
And is it just on the weight loss side of it? Is there a process of the body trying to rebalance? In other words, the body over time, sort of like a process of homeostasis. The body goes, well, hang on, I've now got something turning these GLP receptors on. I'm going to start to adjust my GLP receptors down, sort of down-regulate them to sort of turn off. Therefore, over time, you have to take more of this stuff?
So again, they have sort of looked into this too in terms of the maintenance of diabetes control and weight if you keep people on the medications. It looks like if you can keep taking them regularly, at least
at the prescribed dose,
at the prescribed dosages and at the prescribed intervals, and trial settings that's easy, but that's been supported by the trial. Clinically, we already alluded to the shortages, but in that sort of ideal setting, the vast majority of people maintained their better weight and diabetes control. But it's also true that clinically, there seems to be some small group of people who don't respond so well. And as you're alluding to as well, some people, it just seems to be less effective over time. You probably know this as well, that with these two mainline versions of these incretins, there are high dosages. And that's when those conversations are had with their treating doctors.
Right. So if I could just move on to sort of metabolic health generally. There is I shouldn't say that, from what I've read, more importantly, from what I've learned so far doing this show, and it's been incredible for me, but there's a correlation definitely between people who are type 2 diabetic and overweight and metabolic health generally. Maybe you could explain to our audience what the clinicians like yourself mean by metabolic ill health. What does that mean?
Again, it's a really good question. So I say that I'm a cardiometabolic specialist. So that already alludes to that.
As in heart.
As in heart as well, yeah. Because we know that the overweight, obesity, type 2 diabetes, blood pressure, cholesterol, kidney damage, and cardiac damage are sort of part of this big continuum of disease states. And that the root cause of a lot of them actually is overweight, obesity, not exclusively. There are obviously many risk factors for these conditions, but like a large burden of what we see clinically right now is driven by overweight, obesity. And so when we talk about metabolic health, we're talking about how to look at people's holistically, not just in one part, not just your weight, or not just but your blood pressure or your diabetes control. Or your cardiac disease, but trying to address all the things that contribute to it as well, including trying to tackle, the weight side of it as well. And so, that includes things like looking at blood pressure, looking at cholesterol, looking at people's smoking history, looking at the activity, exercise levels. And the reason why we do that is that we know that if we can improve all those things, people's heart health, kidney health, future health will actually be a lot better.
Yeah, and brain health too, because I've heard that type 2 diabetes is a new form of dementia.
Yeah, yes.
It has been referred to that, I should say. I've learnt that anyway.
Yeah, so we know that diabetes control of diabetes of type 1 and type 2, poor control does seem to actually adversely impact on thinking and cognition. And in these sort of studies looking at older people with diabetes of both types, both main types at least, there's some association with poor control and high risk of dementia and aging with more cognitive problems. That's true as well. Yes.
So is this, in terms of the overall outcomes of, I'll talk about the benefits of the semaglutides in a second, but the overeating or eating eating the wrong things and or carrying a lot of weight is the issue that by doing this, generally speaking, that you're perhaps at risk of clogging or creating a greater risk of clogging your arteries, for example, because the food you're eating is the wrong foods. Perhaps it's high in cholesterol or high in LDLs. Is it also because as a result of that you don't only clog your arteries during the heart, you can potentially clog your arteries in your neck, which feed your brain.
Yep.
And your brain doesn't get enough nutrients and oxygen, and therefore the brain cells start to die off. Is it as simple as that?
No, that's a really good model. Again, to help my patients understand why I may be talking about their weight when they, looking at blood glucose levels, or why am I talking about blood pressure so much, when they want to talk to me about their weight, for example. You're quite right, but these things actually all interact with each other. That's part of the concept of cardiometabolic health. They're not exclusive to each other, and the negative impact is, you're right, actually, it damages blood vessels, both big and small, through a range of different sort of technical, we call them pathophysiological, or the actual disease states that do it. But the end result is actually damage to big vessels and small vessels that increase the risk of, as you said, heart damage, stroke risk, kidney damage. The leading cause of advanced kidney disease and dialysis, that's of end-stage kidney disease, is type 2 diabetes now.
Oh, really?
Yeah, yep. And one of the leading causes of we have to, we're talking a little bit about the other contributing components, to ill health, hip replacements and knee replacements. It's actually driven by overweight, obesity, So, these are the things that people...
Could I just stop you on that for a moment? So that's interesting. So to me, very interesting, because I have someone in my family who just had to get a hip replacement. And I kept saying to him, you've got too much weight. I knew what he was like when he was younger. And you're just carrying 25 kilos too much. And I always thought to myself, it was that extra weight was just putting more pressure on the mechanism, the hip mechanism. But you're saying that potentially that could create hip problems?
Yeah, it is what you said, right? Like a lot of weight just put more pressure on joints and actually cause more wear and tear. I don't obviously pretend to be an expert in the area, but the data does show that, you have higher need for higher rates of osteoarthritis and the conditions that contribute to needing these replacements in people who are overweight and obese as well. So yeah,
that's fine. And overweight and obese. Maybe you could just give me a bit of an idea of that, because overweight's different to obese, isn't it?
Yes, it is actually. Yeah.
So what? How do you work out how do I work out if I'm listening to this, that if I'm obese and at risk, therefore?
Yeah, look, so the technical terms, they're both common terms. We use them, in everyday language. But in the medical space, the clinical space, they do relate to something called the body mass index that many people probably do know about. People argue about it. They say that it's not great for individuals. But on the other hand, it's sort of easy to measure. It's a simple tool. And at a population level, it does correlate ranges of body mass indexes. So one range is normal range. We'll call it normal. Perhaps it's the wrong word, but this is one range. And
it's
there's
the
a
median.
Range. Yeah.
in a statistical sense.
That's right. And then there's another range which is overweight, and then the high range is, ranges of obesity. Yep. And so that's when we say the term overweight obesity, we're referring to individuals as collectively would sit into the body mass index that would be measured as overweight or obese.
So, like, if someone's listening to this, how would they be able to self-measure?
They can self-measure it. It just requires your weight and height, and people could very easily do the calculation. Online calculators are available. It's not determinative, I guess. It's the main thing. I was trying, as someone at this point in their life, if they measure it and they sit within this, overweight or obese, does that necessarily mean they're going to get all the negative things we're talking about? No, it does not mean that. Does that mean that they can't change what the trajectory they're on? No. Does that mean that they're actually unhealthy right now? It may not actually, but we know at a population level these things have meaning.
Yeah, so like someone could be, if you go online, you can, as you just said, you can Google this stuff anyway, or go onto one of the chatbots and have a look.
Yep.
I'll tell you straight up, go to Perplexity or any of the ones you want to use, ChatGPT 4, 5's coming out soon, and it'll tell you how to measure it.
Yep.
And it's sort of a measurement between your height and your body weight.
Yes, correct.
Pretty much. And
Yes.
they know what the universe of other humans are, and they can pretty much give you a body mass index of BMI,
Correct.
Based on the population,
Yes.
the general population.
Yes.
It doesn't necessarily mean you are obese, because you could be a super muscular guy
Correct.
or girl.
Yep.
And it'll say you're too heavy for your height.
Correct.
But that, of course, might not because you've got fat. It might be just you're
Muscle.
super muscular.
Correct.
But within reason, it's sort of fairly accurate, at least to ask the question.
Yep.
So let's say I do it and I
Yep.
look at it and it says my body mass index is, like at the wrong end of the graph.
Yep.
Next question would be, you go and see your general practitioner or someone like that, or
Yep.
if they're lucky enough to come and see someone like you. What do you order? A blood test?
Yeah, so a person, you might know their body mass index, and they would then, especially if they get older, I guess, because we know that as you age, as you move through midlife, you're more likely to accrue metabolic ill health, as we were just talking to, your blood pressure, your cholesterol, and so. Especially as they get a bit older, these things become more valuable, and that's when you do talk to your, hopefully you have a good relationship with a general practitioner, primary healthcare provider, because they can actually do a lot of this. They are trained to, and they're experts in this as much as I am at this sort of level of work. And you do, if you're concerned, you actually would discuss it with them, and they would take a medical history, see if you do have already known conditions, as we discussed. Go through perhaps some of your family history as well. Some people who've got more. A strong family history of cardiac disease, for example, need to be treated differently to someone who does not have it, whether you smoke, whether you've got other risk factors for poor metabolic health. And then they can talk through how you might want to address these things in both treating the individual conditions we're talking about, and also looking to see whether you have got, clinical obesity, which is leading to consequences.
But could I ask you a question? Would you, let's say a person is just muscular.
Yep.
Would you say to them, perhaps you should go and get a DEXA scan or something like that, because you want to see where the fat's sitting? It could be sitting on the inside where you can't see it, because it's not all about subcutaneous fat, the stuff that we see, but it's also about the visceral fat.
Visceral fat as well, that's right.
And that's one of the things you'd be worried about.
Yeah.
Would you put them on a DEXA? Because they're only $150 or something. They're not that expensive. But would you suggest they go do that, or would you put them straight on the blood panel?
I think that someone who's, high, I've got friends who are still quite active physically, right, and have maintained it through as we all get older together. And they've got a pretty good awareness of their physical health. And the body mass index for them is actually, as you said, not as accurate, because they might score higher, but they've got decent lean muscle mass and so forth. I'm not sure they would actually benefit from a DEXA, but perhaps at certain time points in life, as we said, most of my friends have gone through 40 now. So as you get through that point, you might want to do something at that stage, and start looking, and then the next decade as well, at certain time points, key time points, it'd be worth doing that. And I think that's actually part of something that your producer was talking to about, one of the recommendations I'd say would be to look at your health at different times of your life.
And perhaps sort of benchmark yourself. Like at 40, you can benchmark yourself 35, benchmark yourself again at 40, at 45. Yep. I mean, because I hear gastroenterologists say, like, if you've got a familial issue around
bowel cancer?
colon cancer, bowel cancer, probably there are considering recommendations from 40 start to get colonoscopy,
that's
for
right.
example.
Yep.
And then if nothing happens, you go back in another couple of years' time, but you've got a baseline.
Yep.
I mean, it's important to get baselines. So for the people that you come across, are you saying to people, sort of create a baseline once you get off the Ozempic? In other words, get this, lose some weight. So we got a baseline today. You're 50 kilos overweight, and we'll put you on this for a year. I'll look at you every 6 months just to see what your progress is like, and then at the end of the period, I'll compare your new baseline to your original baseline, and that's where you got to try and keep yourself. How important is it for people to understand their baselines? And where they should be. Should I be looking at myself today and saying, I'm 50 kilos over where I should be, because when I was 25, I was 85 kilos. Now I'm 125 kilos, or 135 kilos to make it right. I'm obviously way over the number. So because people are listening to this, and they're trying to work out, well, am I obese or am I overweight? What do I compare myself to?
Look, they're really good questions. I mean, one is you said like a benchmarking, right?
Yep.
And so it is worth benchmarking when you're healthy or when you consider yourself healthy and looking at time points, as we said. If you already might know you have conditions and these cardiometabolic conditions, looking at your blood pressure, if you have hypertension, is actually important. So you need to do it regularly, not just once every 2 years. It might have to be done much more regularly than that, depending on your risk status. In terms of what you were asking about with being on treatment and then relooking it again, I actually do a benchmark, as you said, before we start them on any of these treatments to get, and you said blood panels, blood work to look at their measures that I'm looking into, the blood pressure, the weight, body mass index, the waist circumference, and we do look at the progress over time. And I do it reasonably frequently. I think it helps incentivize people. It gives them some sense that, look, not only am I perhaps losing weight, but look, my blood pressure is better, my diabetes is better, or my pre-diabetes is better if I don't have diabetes, and my cholesterol is better. And sometimes you can go off some of these treatments if you lose, if the incretins help them lose significant amounts of weight. In terms of your listeners who are not sure themselves, I guess if they're concerned about their weight, they might already know, that they've actually been told before or said, look, maybe there are issues with weight, and that's when it's good to have a conversation.
Do you ask them, do you overeat? Do you ever say to someone like, do you feel like you overeat? Because that does take you into the Ozempic conversation.
Yeah, it does.
And what is overeating? Like, let's say, and I know another example of this, but let's say every time you go to lunch, you're the person who eats everything on the plate, and if your friend over there didn't eat his or her chips, you eat their chips. I mean, are there some little signs that we should be looking at? Because there's no point me coming to see you when I'm 150 kilos and I feel like I'm going to faint all the time because I am a diabetic. I'd rather get to see you. I might not be that case, but I'd rather get to see you before I get to that point. But are there some signs that we should be looking out for early, like behaviors? Probably a better way of putting it.
I think if so one thing is that when people reach high ranges of obesity, they often don't eat very much anymore because we know that fat is not metabolically active. And so we actually, we can measure that.
In other words, it doesn't need much energy.
Doesn't need much energy. That's correct.
And not saying fill me up with food.
Yeah, that's right. Exactly. So when you actually look at them clinically, right, or in a trial setting, in a study setting, and you look at food intake as they measure it, or as you actually can directly measure it, they often don't eat very much.
But how do they get there in the first place then?
Well, that's part of what we're sort of saying I think earlier in the conversation, that small amounts frequently over time make a difference. And that actually goes the other way around. Small amounts of weight loss over time can also make a positive difference too.
So how much does activity contribute to this?
It does.
Or lack of activity?
Also does as well.
Is it more, do the studies show it's in terms of being obese or overweight, do the studies show that one is more important than the other? In other words, it's what's going into your gob is more important than the amount of exercise you do? Because some people say, I can eat whatever I want because I train really hard.
Yes.
These could be like old folkloric things. I mean, I don't know if it's all bullshit or not. Has there been any studies to say, look, what you put in your mouth is more important than how much exercise you do?
Yeah, there is. There's some really good studies showing that dietary interventions lead to weight loss, but to lead to sustainable weight loss, it needs to have changes in activities and exercising. So it's certainly the case that I think you alluded to this before, that if you drop weight by changing your diet a lot, it's hard to sustain them. We know that it's very challenging. So behaviorally and culturally, we don't want to be seen to be that different. It's very hard to just eat very small amounts. You get bored of them. They're not filling anymore, behavioral cues, right? We also know that to maintain weight loss, it's best to actually increase your activity level and increase your energy expenditure as well. So both parts are true, Going back to your example of the really fit person, like again, when you really are metabolically active, again, I use examples of friends of mine who were still both studying and actually a good friend of mine was a high level athlete, was still actually working at that amateur level, right? He could eat a lot because he really was burning it off. But for the vast majority of us who are not those people, that is not us. And I think that, so for most people, that is not what they face. They face the issue of, small amounts of overeating over time make a difference. We just talked about how, knowledge-based workers or living in a community that does a lot of driving, we just move less, as we age too, don't we? I have to take my kids to and from school. I'm driving them, I'm not walking to the train station to catch a train to work anymore, for example, right?
Yeah. Like when you're a student, you weren't driving. You're probably catching a train and walking from the railway station to the university, and you probably had no money, so you weren't spending any money on food either.
And I'm old enough as the pre-Uber ages, so I just couldn't get it out.
No Uber.
That's right.
So if how would someone know that they might be a type 2 diabetic?
Sure.
So like, what do they get? Feel dizzy or something? How would they know? What are some signs?
So one thing is to just do those checks, as we said, and a good primary healthcare practitioner would check your blood sugars.
But let's say I don't go to the primary healthcare. I'm just sitting home. I sort of feel all right, but like, I'm just maybe a few occasions something happens to me. What would I be looking for before I go to the primary healthcare?
It happens. Type 2 diabetes happens slowly. The weight accrues on by and large, and it slowly moves them through a stage of pre-diabetes where firstly insulin resistance, so their body makes more insulin to try to control glucose levels within a normal physiological range.
To try and bring it back down to balance.
Yep. And then it begins to escape a bit, so they get pre-diabetes where they get a little bit of escape. The glucose levels are not quite as high, but are no longer normal, and they're still insulin resistant. And that's generally reasonably preclinical. They don't have many symptoms. But it's very common to me. I hear this story, especially where I work in Southwest Sydney, which is a different demographic. People have, they drink a lot, right? They just start losing weight because they're passing the sugar out in the wee, right? They pee a lot. Their vision changes because their lenses in the eye actually start absorbing the sugar and their lens swells up. So they get blurry vision. And of course, they can feel fatigued and tired a lot too. So they might have symptoms of, not just one of them, but often it's many of these things. They say to me, I'm drinking a lot of water. It's very common, right? I'm peeing so much. I'm losing weight. I don't know why. And I can't see. It's a bit blurry. And I'm really tired a lot of the time. And, their glucose levels can be dangerously high. And some of them come into our service and have to be, treated acutely because of their very high range blood sugars.
When you say drink a lot, you're not talking about booze. You're talking about water.
Water, juice, other things, right?
Yeah. Or like fizzy drinks and stuff like that.
And then obviously then you can see that perpetuates it, doesn't it? Because they actually get really high sugars from the fizzy drinks they have or the juice they have. And then your body's still trying to desperately get rid of that glucose levels, right? It's pinging more of it out. So yes, sort of a vicious loop. I mean, presenting sort of some of the more severe symptoms, more subtle than that, but those are the things that people describe.
Because pre-diabetic's pretty important. Because
it is.
Again, there's probably a lot of people potentially in pre-diabetic stage.
More than with type 2 diabetes, they say.
Yeah, more than, And those people are sort of walking around sort of completely unaware of the fact. They think they're okay.
Yep.
So pre-diabetic is when you want to get to them.
Yeah.
But when the medical system needs to get to them, the health system needs to get to these individuals. Would a pre-diabetic person, can they be prescribed semaglutides?
Yeah. So now we go into this issue of how you use these medications, isn't it, right? And in terms of what the evidence shows, what the guidelines are, what the different bodies that I belong to, diabetes specialists, obesity specialists, these medications do have a role in treating overweight obesity.
As a disease
state without type 2 diabetes.
Right.
And it's the actual criteria is actually listed in our regulatory criteria, suggests that we should use it for individuals who have got overweight as determined by body mass index and may have a weight-related complication that includes pre-diabetes or blood pressure.
Could be blood pressure.
Or cholesterol.
It might be 150 over 80, whatever.
Which is really high.
Yeah.
Bad arthritis, for example, we just talked about it too. Yeah.
Arthritis, another indicator?
Because of the weight impacting the knees.
But that's something you would take into account.
Yeah. Yep. Yeah. Sleep apnea.
Okay. Because usually the weight around the gullet there is causing a problem. So that's interesting. So under your regs, because you just can't say, you're overweight, I'm going to give you this, but you've got to have other things associated with it.
And also you've tried other forms of weight loss, lifestyle interventions, and not achieve meaningful weight loss.
So what would you say, doctor, to these people who buy, various brands, GLP-1 agonists? What would you say these people are buying this stuff online?
Yeah. So, firstly, what are you doing it for, right? Are you doing it for your health? Are you doing it for cosmetic reasons? Yeah, cosmetic reasons. There is no clinical indication for cosmetic reasons. And so I don't prescribe, I'm a endocrinologist and a physician. I prescribe as per what the data shows to me and what and what is actually beneficial for people's clinical state. Yeah. health, as it were, right? So that's what I do. And so, yeah, I mean, it's a contested area. It's really, it's hard to balance off very effective medications with a really big need for people to try to, use them clinically, right? Because we just talked about people with type 2 diabetes. We've talked about people with overweight, obesity without diabetes. That's a much bigger
But
group.
nonetheless, they're at risk for other things.
Yeah.
Cardio problems, all sorts of other issues, kidney problems, cardio problems, structural problems, etc.
Yeah.
But those assessments are made by professionals like yourself, like clinicians. But this sort of takes it down the track to. I don't know if there is any studies been done on this, but maybe you could proffer an opinion. Could the reason there is now a shortage of the various semaglutides available for those people who do need them, for example, are type 2 diabetics, is it because that people are being prescribed this stuff and they don't really, or buying it somehow, then they don't really need it? Or is there that many people who are pre-diabetic?
There's both. There's that many people with overweight, obesity who have been trying to access medications So the government says you can use this in this space clinically, but as you probably know, the government doesn't support the funding of it. So these people are buying it privately, and so
but if you prescribe it, it's supported under the PBS.
For people with type 2 diabetes, you meet certain criteria. Yes.
Yep. Okay. But outside of that,
so for the people that I treat with overweight, obesity without type 2 diabetes, they won't be able to purchase them on the PBS, even if they saw me.
Right. Okay. Oh, wow. And even if you're convinced that they're going to have arthritis and blah blah blah, they still don't get it on the PBS. They have to pay full freight for it.
Correct.
But outside of those people who sound to me to be have legitimate reason to have it. In a sense that I'm not saying people are illegitimately getting it, but I'm saying in the sense that given the constraints to supply,
that's right,
it's more important to get it to the ones who really are in demand. So so I would say the universe of people or the population of people who should be taking this, who have demand, are the people that you've just discussed.
That's right. Yes,
those people with some net effect as a result of being obese, whether it be diabetics or other issues, so they should be getting it first. That's just a sort of a personal view. Yeah. But is there so outside of your practice, do you hear about or talk about this predominant people using it for cosmetic reasons?
Yeah, I mean, you probably your researchers might also told you as well. There's a lot of telehealth clinics that have been set up purely just to drive a model, and that's not the recommended model of care. Where you have a single consultation that's asynchronous, as I say,
and they're not with endocrinologists either. No. They're with the GP,
and they're not even at the same time. Asynchronous means that someone's given some information, someone's reviewing that information, right? And that's not right in my head. I believe the data suggests that I believe the data shows that most prescriptions are private, actually. So it is what you said, right? And with both people who buy them privately for the reasons of overweight, obesity, meeting the clinical guidelines we discussed, but you have to wonder whether the majority actually are not meeting those guidelines. There may be cosmetic reasons, as we said, right?
So what if someone, so there is, I don't know if, whenever you interfere in the balance in your body of any chemistry, there's always Newton's law. There's for every action, there's an equal and opposite reaction, and it still applies, irrespective of the fact that a lot of things that Newton said probably have been superseded. But that one always applies. And once you introduce a chemical into your body in the form of semaglutides, what are the side effects that could affect people, particularly those people who are not getting it for a actual net clinical benefit? In other words, they're getting it for a cosmetic benefit.
So they'll be as prone to the common side effects of these medications as anyone else would be. But, they're not going to get the clinical benefits for their health. And often they're using it for very short-term gains. But once they stop it, they'll lose those minor benefits to their weight that they've achieved and all the cosmetic benefits. So, I'm not sure that's actually a really good use of potentially scarce resources.
But is there a side effect? Can it affect your kidneys? Can it cause is there anything that's known about it, or is it relatively speaking safe?
the class as a whole, these GLP-1 RAs, these incretins, have actually been used clinically for a decade. So the first iterations of them are actually quite old. As I was going through my training, I was learning that these things were coming, and as I started my specialty training, they actually were available in the first iterations. These were a daily injection. They weren't quite as effective, but what that means is that we've actually had more than a decade of clinical experience with these medications, even here in Australia, and as well as the manufacturers keep on studying the medications to see whether there's anything that occurs, at a population level as you keep on giving the medications. So their side effect profile is quite well known, as well as a long-term effect profile as well. And there's nothing, there are no major things that have come up to say that these things are potentially harmful to use in the long term. So, and actually, you've got some benefits in heart risk and kidney risk that's increasingly being discovered as well.
But let's say somebody's not obese; they just got an inch of extra fat around their tummy, and they're worried about what they're going to look like when they go to the Greek islands this August. And they start taking this, and they're going to take it for a period of time. Is there a risk of not having enough nutrition?
Well, actually, as you move into normal weight ranges, and especially when people have got not even be overweight, right? I mean, I think you probably know the term Ozempic face, right? And there's various in the gospel.
What does that mean?
If you don't have significant overweight obesity, you've got normal weight ranges, people, we see in front of each other. If we strip off our weight, we might lose a little bit here, but we also start losing fat in our face, and that actually doesn't come back. And so,
really?
Some may not come back. No, especially if you've been on it for a long time, right? And so, when you were talking about some of the unintended consequences of using it without meeting the clinical criteria, that is to say, people are not overweight, obese, that can be one of the issues. You already said that you can lose weight, and you can lose weight in your face, and your face might change your appearance. You can suppress your appetite a lot, and given that you don't have much weight to lose, we talked about how you lose at different parts. You might lose some muscle mass as well. That could be an issue. And you're right. The profound side effects. You can get some of the common side effects, and there are 5% of people who get really bad side effects when they use these medications. The nausea and vomiting is really quite profound, or they might have other gut problems like constipation, diarrhea. These are not pleasant things to experience. If you didn't need it, if you weren't going to benefit from it clinically, I'm not sure why you necessarily put yourself up, for that chance of getting those side effects, for example.
Yeah, so that's interesting. What you said about the losing the fat in your face, which basically gives us in some part, other than your jaws, your bone structure, it gives you face shape. And you mentioned that you could lose it and it doesn't come back.
Yeah. So I mean,
is that how fat works? Fat cells is cells. So are they? I don't know the answer to this. I'd like to know. Do we have fat cells sort of somehow genetically deposited in all various parts of our body, but they're sort of not active, or they're not full? They're sort of only part full, and when you supply them with sugar and other things, you make them bigger. How does the fat cells work?
Yeah. So you're asking, like, do adipocytes, fat cells, do they come and go? They do, right? So obviously, but the ones that they generally add stuff into them. So you're right. Actually, they do become fat cells. These things are actually just storages of fat, basically, right?
They're there to store fat.
They're there to store fat, exactly.
Well,
right.
they're there to store energy in the form of fat.
Correct.
That you haven't used once you've taken the sugar in.
Correct.
And that's sort of what insulin does for you. It actually grabs hold of it. Yeah. And puts it. But does insulin grab the excess sugar and put it into your liver, and your liver then sends it?
You obviously done this research. So you're right. It actually has many actions, and part of it is to move glucose away from from bloodstream into cells. So there's insulin receptors in cells that get turned on and so forth. It has effects on the liver as well, as you said. Glucose is used as a storage form called glycogen in the liver. We talked about how fat works too. So excess glucose in the bloodstream is then diverted into pathways that actually stored as fat. And it's really interesting. I don't want to diverge too much, but what I learned through my PhD was that the human body is designed to store energy because for our existence, most of our existence as hunter-gatherers was in energy-scarce environments. So our body tried to hold on to any extra energy we had.
Become very efficient at it.
Yeah, and becomes really efficient at it. That's why it's so hard to lose weight, because most of the hormones actually try to get us to protect the weight we've got. And they've done some elegant studies that show that you lose weight and your body reaches a set point and just tries to put the weight back on. That's what happens. And that's why you're going to, one of your earlier questions was, if you just change your diet, can you sustain the weight loss? And the reason why you can't is that your body then actually starts counter-regulating.
Because we've just been through a drought or a starvation period.
That's right.
Or some famine.
That's
your
right.
body goes, wow, you've been on a diet, Mark.
Yeah.
It doesn't know I'm on a diet.
Yes.
I haven't done it consciously. It thinks I'm in a famine.
Correct.
And it says, well, next time you get a few good meals, dude, I'm going to store that.
I'm going to be more efficient in storing it. That's right. And I'll start putting it back into fat. That's exactly right.
Because I've often wondered about this. This is probably a different issue, maybe not your expertise, but would it be fair to say that a person who puts on weight quickly is a very efficient person?
You mean in terms of storing energy?
Yes.
That's probably one way of thinking about it. Yes. It's probably very reasonable.
But they probably wouldn't like to know. They would probably like to know that because a lot of people who put weight on really easy go, oh my God, I put on weight so easily. Dude, you're just really efficient at
processing.
You're very, very good. Like actually, you're quite in an evolutionary sense.
Yes,
you're better than me.
That's actually I was about to say. Actually, in terms of the hunter-gatherer societies that 99% of human existence has been on, this person's genetically got
blessed.
That's right.
So anybody listening, you're blessed. Okay, that's the truth. And what we've got to do is we've got to what Ozempic does, or what these particular drugs do. This class of drugs, the GLP-1 RAs,
or incretins.
What they do is they actually stop your efficiency in some respects.
Yes, they do. Right.
So it's a bit counterintuitive, but it works. But we were talking about a moment ago about the effects on people who don't need this,
especially when they don't have overweight. Actually, got normal weight.
And you went through a number of things that anyone would be at risk of. That is, like guts problems, etc. But what about things like, as a result of not eating enough, you're missing out on some nutrition. For example, you don't get enough calcium.
Yep.
Like you can end up getting, bone issues.
Yep.
Is that something that's been seen? Because this has been around for 10 years now, you're saying. So maybe they're seeing this already in the research.
So we know that if you lose a lot of weight, including people who've got normal weight ranges, and, there's been sad studies looking, doing famine periods where people have looked at what happens to people's bodies, when they don't get much energy and lose a lot of weight. You lose muscle and you lose bone. And obviously, if you've starting off with a normal weight range and you're doing it by medication for the purposes of cosmetic benefit, you might lose some muscle mass and you might lose some bone mass. And, the question is whether you get it back when you stop taking it. Uncertain how effective it is. And if you lose a lot of it, you may not get it all back.
And your body is, we were talking about efficiency a moment ago. And one thing I'm pretty sure I learned this, but in one of my interviews, but your body's so efficient that if it feels as though it is starving or is in this famine sort of state, it actually can start to convert your bones into energy. It's one of the areas it goes to, apart from the muscles as well. It'll eat its own muscles, but your bones as well. So you're actually attacking your own body. It's nearly like an autoimmune disease.
Your body is really like you've got such profound appetite suppression from these powerful medications. Your body needs energy, as you said, just to tick along, right? And it's not getting it from you have few fat stores because you start off being a normal weight, really. If you've exhausted them already, you've lost it in your face, you start looking much older. So actually, in some ways, it works against your age, doesn't it, right? Sorry, it works against the cosmetic benefit because you look older than you are if you lose the face, the fat in your face. And you were talking about, yes, it starts then converting your muscle and starts breaking that down to triglyceride glucose. And the extreme end, especially as you lose muscle mass, you're not protecting your bones as much. You can start reducing your bone mass as well.
It's really interesting because that sort of takes us down the territory of longevity because I was just thinking as you're speaking, in terms of longevity, if you don't need to take, well, there's two parts and they're equal and opposite. If you don't need to take Ozempic, for example, and you are taking it for cosmetic reasons, not only are you potentially run the risk of not looking so great, but if it starts to put you in a position where your bone mass and your muscle mass starts to get reduced, in terms of your longevity, you might be starting to put yourself at risk of falls.
Correct.
And or any other number of things that could create a problem for you. You could fall, break your hip. You could fall, break an arm. You could fall, do your wrists, hands, create arthritis. There's just a whole plethora of things that could go wrong with you. And in fact, and ultimately, or statistically at least, those sorts of injuries not only set you back, but they actually are translational in relation to in terms of studies as to how long you might live.
Correct. Actually, you're right, actually. So, you're more risk of falls if you lose certain degrees of muscle mass. And if you've also then reduced bone mass, you're more at risk of fracturing. And as you're already saying really correctly, a hip fracture is a known risk factor for an early death,
Because it stops your movement. You do something bad, and like a hip, let's say you get a hip replacement for argument's sake, but you're out of action for a long time. You're not moving. Everything is starting to deplete even more and more and more, and other things can happen to you.
Correct. In hospital, you get sick.
Yeah, you get sick, and you're actually reducing your longevity. So ultimately, cosmetics important, I guess, but ultimately, it's the longer you live, and the better you live that period.
Yes,
that's really what our game's about. Trying to live as long and as good as possible. If you don't need this medication, then you are potentially shortening that period, or running a risk of it, at least statistically. But maybe if you could just go on the positive side too, because if you're way overweight and you are obese, these drugs actually may well increase your longevity.
Yes. So people who've got high ranges of obesity, we talked about how they can develop these conditions, and these conditions are all known to shorten your life, through cardiac disease or kidney disease. And addressing the weight part of it as well as treating the conditions would actually, help you have a lower chance of heart disease, a lower chance of advanced kidney disease, and that therefore have a better and longer quality of life and a longer duration of life as well. And these medications actually are now known to actually reduce heart risk. There's really been some really powerful studies in people with diabetes and overweight obesity, and with the two main medications that are currently available here, showing that they actually reduce heart risk. The people actually get less heart failure, which is a great thing. And and with Ozempic, with semaglutide, they get less kidney damage as well.
That's interesting. You should say that, because my good friend at Neura, the CEO of Neura, Matthew Kinnan, Dr. Matthew Kinnan, Professor Matthew Kinnan, I went to see him about my mother died from motor neuron disease or complications as a result of MND, and so I was, but she was quite old when that happened, and I was quite interested to see, what my predisposition is to that, apart from getting genetic testing, etc. And I went and saw Matthew about it, and he said to me something very interesting when it comes to just general brain diseases. He said something to me: "What's good for your heart is good for your brain, and if overweight is bad for your heart, ultimately bad for your brain."
Yes, it is.
And I said to him, "Well, one of my uncles has got dementia at the moment, or he's in that early stages of dementia, and he had a number of strokes, I said to him that he has vascular dementia, and so the first thing that Matthew told me to go and get my carotids checked to make sure through lifestyle. And my uncle's fit looking guy, but some people have this ability to clog their arteries or the carotids going into your brain, which, as I said earlier, actually sort of limits the amount of blood and nutrition, oxygen, etc., goes into your brain cells, and your brain cells start to die off, and that's what vascular dementia is.
That's what vascular dementia is.
And I mean, if you're wanting to improve your longevity and the way you live, because no one wants to live with dementia. It's the worst for your family, especially.
Yeah.
But, this process of losing weight, if you're at risk from weight, Ozempic and all its various brothers and sisters would be a bloody great idea.
Yes. Yeah.
And I think that, so given it's been around 10 years, but we've only started to talk about it, why do you think all of a sudden we're just talking about the last 18 months? What the hell is that about?
So firstly, Ozempic is an iteration. As I say, it's an advancement on the previous ones. And so it was much more effective, and it's in terms of its diabetes effects and weight effects compared to the earlier generations.
And easier to deliver too.
Yes, that's right. The actual device itself is easy to use.
It's not a needle. You don't have to withdraw anything out.
No, it's a pen device. You touch a small, we'll call them insulin needles, but small fine gauge needle onto the pen device. You dial up the dose and you inject. So it's actually relatively simple. Yep. And it also, you're asking why is it popular right now?
Yeah.
I think it actually came about during the pandemic, because I know in Australia it was approved in the late 2010s, right? And we had about 1 or 2 years to use it before 2020. And so we were starting people with type 2 diabetes on these medications. And suddenly, I think the lockdowns and then the increased focus on yourself and your health there, and the
time to research.
People were on the internet a lot, and it really picked up overseas. And those things I think took pharma by surprise as well. How powerful it really was. I think this is the first example of a viral trend affecting a prescription medication. People know the word Ozempic who wouldn't know the name of any other sort of form of diabetes medication,
Yeah.
So, so it just really took off like a rocket. And then it was obviously then used, people were promoting it on their social feeds and so forth like that. And so that just amplifies.
So it's more about how much we share.
I think it's also about our culture, isn't it? How much we care about what we look like, I reckon.
Yeah, I think that's got a big part of it. Yeah. And we did talk about this before the show started, but I thought, and you've corrected me, but that the injection or the injectables had been replaced by, or potentially replaced by a pill. But you mentioned there's always been a pill around, and it was been a pill around for a while.
Yep.
So could you just give us a bit of a background on those two things, pill versus injection? Why take one, not the other?
Yep. So I think you were just asking this too, Mark, that the bioavailability, the ideal, that's the term, technical terms to say that is the medication absorbed. And what we do know is that with these medications, if you take it in tablet form, the body breaks it down very quickly before it can get into the bloodstream. The gut breaks it down, and the gut processes break it down. So they're just really trying to create some type of coating that would allow those medications to be absorbed from the gut, and they haven't quite got them there yet.
They coat it so it stays in the gut or goes through the system.
And then goes through the duodenum where it gets absorbed, so it gets through the stomach.
Yeah. It's about getting through the tummy into the lower intestine.
That's right. Yeah. Where they can start being absorbed. That's right.
Yeah. So it can be absorbed, yeah.
Well, we know that you're just asking me about how they work, right? They're quite stable when you inject them, and there's your own fat acts as a good delivery device for the medication. So they're just very effectively absorbed that way too by injection. So that's why the injectable forms have been the dominant way these medications are used.
Did you think when you did your specialty in endocrinology that you would ever be be moving into stuff that's really mainstream? It's got something to do with heart, it's got something to do with saving people's lives, it's got something to do with longevity. Do you ever think that the endocrinology world would start to be really important in terms of the metabolic world?
I think I'm young enough to know that, to be at that time point when that was beginning to evolve.
But older endocrinologists never got into this territory.
I think, and one of the paradigm shifts for endocrinologists in the diabetes space, so we're saying that I do a lot of diabetes, is that we're not just treating glucose. We are treating the holistic whole health, the metabolic health. And I think that's really a big paradigm shift. You're not just treating someone's blood sugar levels, you're treating their blood sugar levels as it impacts their health, the heart risk, the kidney risk, and their metabolic health. That's really important. And one of the I actually had a number of mentors at the earlier stages of my career, including at Prince Alfred. And actually they taught me that. They sort of knew that as well. And that's one of the benefits. And I think it's one of the honors I had actually of being taught by people who saw that really early on in the process.
Saw the future of it.
Yeah, saw the future of it, really, yeah.
So would it be, is it fair to say that you're sort of like you're maybe an endocrinologist, but you're sort of a metabolic specialist?
Yes, I would call myself a cardiometabolic physician as well.
Oh, that's what you call yourself? Yeah. So a cardiometabolic physician. Yeah. So metabolism relative to your heart.
That's right. Heart health, again, that concept of heart, kidneys, weight, diabetes, it's all part of, part of the underlying conditions that you're treating when you're trying to treat someone's diabetes well. So that's one of the things I would call myself. Yes,
because one of the things I learned also in this journey is that still the biggest killer in the world is heart. By far. Actually, by far. Second place is cancer.
Yes.
But there's a fair bit distance between cancer and hearts. And third is brain disease, and fourth is metabolic related diseases, which could be heart, could be anything, could be kidneys, could be whatever any one of those things are. And it's interesting that those, some people refer to those as the four horsemen, but in relation to where medicine is going today and what you're doing, and you've kindly given us your time and expertise and intellect and et cetera today.
Thank you.
But what's interesting is that those four territories are sort of the most talked about from a medical practitioner's and a clinician's point of view today. That's the most relevant to anybody. And it's you're sort of in a very sweet spot because you actually cover a lot of that. You cover heart as well as everything else. You're covering quite a number of areas there. Do you ever feel to yourself a bit of a burden that's, that you feel as though, well, I'm responsible for something here and I really should make sure that the literature's good, that my research is up to date, from not just as being a clinician, but also being ahead of the times or alongside the times. And what do you do? What does someone like you do? How do you keep abreast of what's going on?
Again, I think I was fortunate to see this coming on early. So I've had a long-term interest in this area, and so I do keep on top of the literature and as it evolves and the treatments. And I've been really pleased to see these treatments come through as I graduated and moved into practice, and then moved into specialty practice. These things have really come about. I was alluding to that they've been around for 10 years, isn't it? Right? And talked about Ozempic's been there since the late 2010s, and this has really changed the way that we can actually manage these conditions. And
is it revolutionary then?
I would say yes. I mean, there's quite a few of my colleagues and I think that this thing has changed the way we manage overweight, obesity, and how it impacts on diabetes risk and heart risk and kidney risk. And I actually increasingly see fellow career cardiologists and renal physicians who actually say, look, the three of us are treating very similar conditions, because the root cause of a lot of it, you were sort of saying heart disease, right? I've read somewhere that they predict that overweight obesity will actually overtake the impact of smoking on heart risk if it hasn't already done so. It's set to do so, in the near future. So if people try to reduce smoking for a range of interventions, right? But this is one way this is a tool. It's not the only thing, right? But it's a really powerful tool that helps us to address overweight obesity, which is a risk factor for heart disease, And we're talking about how the big burden on health spending is dialysis, right? And the biggest driver for dialysis is type 2 diabetes. And again, the main thing driving type 2 diabetes is overweight obesity. So we really can go into a space now where if we can catch patients when they're younger and before they have advanced conditions, we may be able to actually pause their disease state and reverse it, potentially if they can do really well with these medications. And I think we're alluded to, it's still important to focus on lifestyle changes and diet and exercise, because the studies and my real world experience shows that people who engage with the lifestyle intervention actually do better on these medications than the ones who rely on the medications to be driving their weight changes. In
other words, taking medication with being sedentary or something like that and doing nothing.
Yeah.
That's from my point of view, I'm lucky I'm not in that category, but and I guess some of it's got to do with genetics, et cetera, and choices. But I feel as though what these drugs are doing now is that they have finally put a full stop after all these crazy diets that people try to talk other people into getting onto. Yep. I mean, it is a diet. It effectively creates a diet for you because it stops you from being hungry, but it actually puts a full stop, and all the quacks out there promoting this diet and that diet and blah, blah, blah. And people so often are frustrated trying all these things and it might work for 3 months, but that's it. As you said, it comes back after 3 months and people get frustrated and they get upset with themselves and they start to feel bad about themselves and then they probably start eating again. Yeah. Yep. It's a bit of a vicious cycle. Yep. And unfortunately, there are people who, that just go through this process. And so, a lot has been said about Ozempic, et cetera. And, a lot of people like to put, like jump on it from above. But even if it's if there are going to be some people take the piss in relation to whether they should or shouldn't have it, I guess they're taking their own risk. But ultimately, the overall benefit is so great. Yep. It's so important.
Yeah.
to help people.
Yes, it does. And I think it's put a full stop on the idea that overweight obesity is purely a failure of willpower, but it's not that. We're talking about how our society actually encourages us to gain weight through these. We live in an obesogenic society, and modern society is one that promotes weight gain because of the things we've discussed, right? The impact of aging makes it harder for us to address that too. And our mental health has been impacted by a range of things in our modern lifestyle that make it harder for us to resist the temptation and the comfort that comes from eating.
And I think that's the word, Namson, it's comfort.
Yeah.
And we feel, I think as society today feels much more discomfort today.
Yes.
As a result of just being a member of society, apart from the pressure and the speed and et cetera of society. And discomfort can get cured by comfort eating.
Correct.
And I don't blame anybody for putting weight on as a result of what they're putting into their mouth.
Yeah.
And a lot of times socioeconomic reasons decide what you put in your mouth too.
Yep. Where I work in Southwest Sydney, I see a lot more of it than where I work in Central Sydney.
Yeah, because people can't afford to eat. And this is, I hate to be boring, but this is a lot to do with the cost of living crisis we currently are undertaking, both here in America and other parts of the world. And the cost of living crisis always affects the lower end of the socioeconomic scale.
It does. That's true.
And the options for the lower end of the socioeconomic scale are hamburgers or whatever, and they just need to be satiated for the moment.
Yep.
And the kids as well.
Yep.
And it starts with the parents and ends up with the kids.
Yep.
And if we could get, if these people are clinically unwell, as determined by someone like yourself, then the PBS should be paying for those people, in my view.
Yeah.
Because ultimately it helps society out, because it means they're going to be less reliant on us fixing them up later on down the track. So we better off get them into a better style of behaviour now.
Yep.
That's just an overall economic view. But I really appreciate Namson, and I've learnt a lot for a start. You've cleared up a lot of things that I have no idea about, and in fact, a lot of stuff I was confused about. There's a lot of stuff in the social media world about this Ozempic, etc. And your generosity today is much appreciated.
No, really. Again, thank you for the opportunity to talk about this.
It's been fantastic.
That's great. Thank you.